So we are going to go ahead and get started this afternoon. Welcome, everyone. My name is Elizabeth Aloni. I'm with Schneps Media. Schneps Media is the largest local media company. We publish over 80 newspapers, magazines, websites, webinars, podcasts, and events throughout Queens, Brooklyn, the Bronx, Manhattan, Westchester, Long Island, the East End, Philadelphia, and even Palm Beach, Florida. And today we are thrilled to be able to bring you the Weill Cornell Medicine team from New York-Presbyterian to discuss and answer questions about advances in prostate cancer screening and treatment. And we're going to learn more about New York-Presbyterian's comprehensive prostate cancer program. And we're also going to have an opportunity to ask the questions that you have. So please do not be shy. So I want to get started by introducing our esteemed panelists. First, please welcome Dr. David Nanus. Dr. Nanus is a professor of medicine and urology at Weill Cornell and director of the New York-Presbyterian Hospital Weill Cornell Medicine Healthcare Systems Cancer Program. Dr. Nanus has extensive clinical, scientific, and administrative experience overseeing the division of hematology and medical oncology at Weill Cornell from 2004 to 2019. He's mentored many junior faculty throughout his career, including physicians, physician scientists, and researchers. He's a medical oncologist who specializes in prostate cancer, leading and participating in numerous clinical trials related to prostate cancer and other genitourinary cancers. Welcome, Dr. Nanus.
Good afternoon. Pleasure to be here.
Thank you so much. Next, please welcome Dr. Manchu Negar. He is a board-certified radiation oncologist at New York-Presbyterian who specializes in caring for patients with prostate cancer. Dr. Nagar received his undergraduate degree from Johns Hopkins University and his medical degree from the University of Texas Health Houston. He completed his residency at New York-Presbyterian Hospital, Weill Cornell Medicine. Dr. Nagar is the recipient of numerous honors, including the Physician of the Year Award from New York-Presbyterian Hospital, along with multiple research grants, scholarships, and awards. Dr. Nagar uses the most advanced technology available for patients with prostate cancer, including real-time MRI guidance and rectal spacer to deliver safer radiotherapy in 5 or fewer visits. Welcome, Dr. Nagar.
Thank you, and happy to be here.
Wonderful. Next, please welcome Dr. Nausheen Hakim. Dr. Hakim is a hematologist and oncologist at New York-Presbyterian Queens Hospital and an assistant professor of clinical medicine at Weill Cornell Medicine. Dr. Hakim has a special interest in the area of genitourinary cancers. She graduated from New York College of Osteopathic Medicine and completed her internal medical residency at Drexel University, Hahnemann Hospital in Philadelphia. She served her hematology and medical oncology fellowship at the Northwell Health Cancer Institute. With a commitment to working in global health, she strives to better understand palliative care barriers in communities abroad and at home. Welcome, Dr. Hakim.
Thank you very much.
And finally, please welcome Dr. John Graham. Dr. Graham is an attending urologist at New York-Presbyterian Brooklyn Methodist Hospital and assistant professor of clinical urology at Weill Cornell Medicine. Dr. Graham is a fellowship trained in urologic oncology and complex robotic surgeries of the kidney, ureter, bladder, and prostate. He also has experience in providing innovative technology for benign prostatic hyperplasia. Welcome, Dr. Graham. It is truly an honor to have these doctors with us today. So thank you, Dr. Graham. So let me get started with Dr. Graham. So screening guidelines for prostate cancer seem to always change. So if you can help us get clear about what the current screening guidelines are for prostate cancer.
Great. Well, thank you so much for having me. I'm very excited to be here. And I think that's a fantastic question. And what the first point I want to make is the screening starts with a discussion, regardless of age or any other associated medical comorbidities, other problems. Your discussion is the first step in this whole process. We want to individualize a lot of your care moving forward just by meeting you, first of all. And the reason why these guidelines seem to change so much is because they have recently been changing quite a lot. the first thing to understand is our goal in the realm of urology is not necessarily to diagnose prostate cancer. Prostate cancer is a very common diagnosed cancer in men. Our goal is really to find clinically significant prostate cancer, or cancer that's going to end up hurting you or causing the end of your life or your loved one's life. So our goal is to individualize the screening process. So that starts with a discussion. Then from there, the guidelines generically would start at the age of 55. So according to the AUA, we do not start screening an individual before the age of 40. Between the age of 40 to 55, there are individuals that we would identify in that discussion who are at an elevated risk, who aren't necessarily at average risk. That would be individuals like Black men, African-American men, individuals with a first-degree relative that have cancer, like prostate cancer, or a cancer that's similar to prostate cancer, and then individuals who have certain genetic mutations, the BRCA, BRCA mutations. These are individuals that we would consider screening earlier than the age of 55. And then when you get into the big cohort, the big chunk of patients between the ages of 55 to 69, we start screening these individuals at an annual or every other year basis, at least touching base every year to try to understand how you're doing, what's going on. And then as an individual gets older, the guidelines for individuals at the age of 70 to 75, again, we're individualizing what you're screening or what our surveillance of your risk should be. We take into account how healthy you are, how long you expect to live, what your goals are going to be, and how you see your healthcare moving forward. So it really starts with your first discussion, the first meet, and we want to make sure we take our guidelines, but we individualize it in a shared decision-making capacity to what you want and how we can help you.
Elizabeth, can I say one other thing? I think it's important that the audience recognizes that while prostate cancer is the most common cancer among men, but still most men don't die of prostate cancer. And even if, as Dr. Graham alluded to, even if you get diagnosed with prostate cancer, it's not a death sentence. Sometimes there's a fear among individuals that, well, if I get screened and I have cancer, I'm going to die, it's going to affect my life and so forth. And that's really not what happens in prostate cancer. Frequently, we don't treat patients, and frequently we follow them closely. But even if you do have to get treated, it's highly curative, like many cancers, when diagnosed early. So when we as healthcare providers, why we emphasize screening, whether it's breast cancer or cervical cancer or colon cancer or prostate cancer, is because early diagnosis does save lives. And so I think it's important for people to recognize, I realize there's a fear factor about getting screened for any cancer, but the upside far outweighs the downside. So I would encourage patients to, for them and their loved ones that are at risk to undergo prostate cancer screening.
Thank you. And that provides a wonderful segue to Dr. Nagar. I wanted to talk about that because men really are often fearful around prostate, cancer screening, being diagnosed, but also requiring life-altering therapies. But there have been advances. So could you share, Dr. Nagar, can you share with us a little bit about, what some of those advances are and, why men shouldn't be so afraid to go ahead and get screened and even potentially deal with some of the therapies?
Right, exactly. Thanks for the excellent question. And it really dovetails well to your previous question and what Dr. Graham and Dr. Nanus mentioned, that getting screened allows for early detection. And early detection doesn't necessarily mean early treatment. And so there are multiple active surveillance programs that are available to men. So while they may be diagnosed with a low or favorable risk prostate cancer, it doesn't necessarily mean that they need treatment at that point, and they would continue surveillance with their physician because, as Dr. Graham pointed out, we're not here to diagnose and treat insignificant prostate cancer or just any prostate cancer. We're looking to come in for treatment at the point where that prostate cancer has the ability to spread or cause quality of life issues for that patient or their loved one. So even if you screen and are diagnosed, it doesn't necessarily mean that you are going to require treatment. And furthermore, as Dr. Nanus pointed out, it's early detection leads to early cures, and also the fact that there's more on the table for interventions and choices patients have the earlier they're diagnosed and require intervention. So if a patient may be diagnosed later with more advanced prostate cancer, some of the treatment options won't be available if they had been diagnosed earlier. That being said, it does not mean that advanced prostate cancer isn't treatable. It just requires more intensive treatment, and not everything might necessarily be on the table for them. So I'll let Dr. Graham speak as to the surgical options, but in terms of radiation options, radiation oncology has changed a lot within the past 5 or 10 years, where men would have to come for treatments for multiple weeks at a time, and it would be a serious impairment on quality of life in terms of actually getting your prostate cancer treated. Ourselves, along with many other institutions, both in New York, in the States, and abroad, have data to suggest that patients can be treated for a very shortened amount of times, as short as 5 sessions to treat prostate cancer in the curative setting, meaning they've not had a prostatectomy. Even so, if a patient has had prostatectomy and may require treatment afterwards, that burden of treatment upon that patient or that loved one isn't as intense because the treatment sessions have decreased. And the reason for that is we've learned a lot more about prostate cancer and the biology of it, but the technology has advanced so much in the past few years, where we've had markers to place in the prostate or the area you want to treat so we can see the anatomy better, to real-time MRI guidance, where we're actually seeing the prostate in real time and can avoid some of the side effects that men do worry about, including urinary side effects, bowel side effects, and sexual side effects. And additionally, it's just not such a burden onto those men coming for treatment, and the side effect profiles have improved over the past decade. And sort of going back to the beginning is, just because you're screened and are diagnosed doesn't necessitate that you will get treatment, but at least you're catching at an early point where surveillance or single modality or one type of treatment, whether it's surgery or radiation, could possibly well be a curative option for you. So it's important for men and their loved ones to understand that, getting diagnosed doesn't necessarily mean treatment, and the treatment options do have more favorable side effect profiles than they did in the past.
Well, that's some absolutely wonderful news, and really encouraging people to make sure that they are tested, because when it's caught early, it's easier to be dealt with. And no matter what, it seems that you've made tremendous advances. So Dr. Graham, perhaps you can walk us through, if something in a screening does result in raising concern, what is the process and how does the team address this?
So when you go all the way back to individualizing the screening, it starts with the discussion. And then from the discussion, it can involve, and I think that this is where what Dr. Nanus was talking about, fear. Sometimes there's a level of perceived discomfort. You come into the office and it's mandated that something uncomfortable may be introduced to you, something like a rectal exam. So that's not something that ends up being by guidelines that's absolutely mandatory. And this is something that in our discussion, we individualize to what you're comfortable with and what your goals are. So the screening process would involve history taking, talking about your overall health, your family's health, and so forth. It can involve a physical exam, and it will involve likely a PSA test. That's a blood test. It stands for prostate specific antigen. It is a protein in your blood that, if elevated or abnormal based on your age, would then potentially set off further exploration. The generic number we would use can be 4. But we realize that we're individualizing this to you based on your risk factors and your age. So the number may be lower, it may be higher, depending on what we identify when we sit down and talk. If some of those early discussions and blood work were to identify an individual worth screening, from there we would at least order likely a prostate MRI or a multi-parametric MRI, where we would gather some more information in order to understand what your risk factors may be and if we needed to move in the direction of a biopsy. So it doesn't automatically set off the need for a biopsy, but as things may set off red flags, we just further investigate to ensure we can individualize what will be the next step in your treatment process in order to identify if you have, as Dr. Nagar and Nanus both identified, clinically significant prostate cancer, cancer that can hurt you. So it would be an MRI and potentially some more blood work that can put you on a risk scale.
Now, what would be the first step for a patient? So they're seeing, let's say, their general doctor each year. At what point would you recommend that they see a specialist to talk about prostate health and prostate cancer?
So it's a great question. You know, I think in general, prostate cancer discussion can lead into a lot of men's health discussions. So I think going and seeing your doctor regularly, starting at the age of now, is a great idea, regardless of your age. And then that individual can tailor the screening of prostate cancer based on your risk and age. So generically, men at average risk of prostate cancer, we would start their screening at age 55. However, if you started to present to your doctor at the age of 55, a lot of the other benefits of just presenting to a doctor can be missed, a window for colon cancers and other health benefits. Screening earlier would be if you're at elevated risk. And like I said before, African-American or Black men with a family history of prostate cancer or cancer similar to prostate cancer, or individuals that have genetic mutations that may put them at an elevated risk. So you want to make sure you're seeing your doctor now, regardless of how old the individuals are on this webcast, but we would start to use some of those guidelines as to when to start screening.
Yeah, and let me just add to that. There is a little confusion out there as to what a normal PSA is. And I think that's something that patients should be aware of, because not everybody understands this. If you look at the lab test, it says less than 4, but 4 is just an artificial number in some regards, because it has to do with age, the size of your prostate, and so forth. So especially men who are at high risk, which are, if you have a family history of prostate cancer, or even a breast cancer, or you have a genetic mutation, most people don't know that, or if you're a Black man, even a slightly elevated PSA at age 45, a PSA of 2 at 45 may be abnormal. So, you know, we have general guidelines we like to go by that we at our institutions, New-York-Presbyterian, which includes Queens, New-York-Presbyterian Queens, Brooklyn Methodist Hospital, as well as in Manhattan on the Upper East Side at Weill Cornell, that we follow more or less. And when we think patients should be referred, even a PSA above the age of 1 in a high-risk man in their 40s probably should see a urologist like Dr. Graham. Between 50 and 55, probably if it's more than 2, you should see someone. So there's general ideas about when you should see. I think the most important thing is to get your blood tested, your PSA tested. As Dr. Graham pointed out earlier, if you're high risk, if not, starting at age 55. And then based on that, you may need to see a urologist. You know, if it's 0.5, you're golden, that's it. You know, you just have periodic PSA tests, but obviously, even if you have an elevated PSA, it doesn't mean you have cancer, but urologists are really good at helping you determine, you know, if and what needs to be done.
Thank you.
And to sort of finish off that sort of statement, it's more, you know, the reason we're recommending early active screening is that no one should hang their hat on one laboratory value or one test, right? So the earlier guideline appropriate that you get screened, your urologist or healthcare practitioner will have a trend as to what your PSA started with, will have potentially the anatomy of the prostate gland, and take various other factors into case as to if your PSA is elevated, is this something that is, you know, due to benign causes, or it's something that would alert to investigate further. As Dr. Graham mentioned, there are certain other blood tests that can be done along with imaging to determine the benefit of potentially engaging in a biopsy to discover prostate cancer. So it's important, you know, for us to have a velocity or a trend of where your PSA started, because if we start with one value, that's all the information we have. And, you know, not necessarily the best decision we made with one simple laboratory value.
Fantastic. Thank you for that. I mean, it just makes me want to implore everyone, please see your doctor. Please don't wait. No matter what age you are, have these conversations, see your doctor, and just know where you are. Not knowing is so dangerous, and knowing, I mean, just from what you're sharing with us here is treatable. So, you know, I just felt the need to say that. But, you know, also, Dr. Graham, I just want to quickly touch upon COVID, because some people are still concerned about COVID. It's still there. How has that affected screenings? You know, Are you seeing patients in person? Can a patient have video visits? We certainly don't want people to miss a visit because of COVID. So what do you recommend?
I think that's a great question that really is applicable to this kind of experience that we're all living in now. The most important thing, and I keep coming back to it, is having that discussion. We are actively trying to just make ourselves available. We want to provide access to the patients in the community in order to start the screening, start the discussion. And we can individualize that screening. So right now, we have the ability to see patients on a daily basis through video visits. You're in the comfort of your own home. We're able to connect. And should it be of value to send you for a blood test, we can arrange for that to be done at a local lab or to invite you to our office to provide a blood sample and leave if necessary. Of course, there is a role for a physical exam in this, but if that is going to be a hurdle to you getting a level of screening or to discuss, that's not absolutely mandatory. So we want to make sure that those video visits are available to make sure that we're screening, and the screening is talking, the screening can be blood tests. So we can work around it, but we certainly are seeing patients as a full template in our office. We're utilizing, kind of COVID safe metrics in order to keep people separate and safe, and using precautions, masks, hand hygiene, etc., in order to make sure that our full office volume is able to be maintained while still providing the opportunity for patients to be seen in a video visit.
Wonderful. That's wonderful to know.
Sort of echo that, I know we're focusing on prostate cancer screening and treatment, but yearly men should be getting checked for, their blood pressure, hypertension, high cholesterol levels. So this is just another blood test to add on to that. But it's important to not just do the blood test, but have the conversation as to what that blood test means, right? Because we also see men that just see their PSA, and according, like Dr. Nanus mentioned, 4 is this number. If you're below it, you're okay. If you're above it, then you're concerned. It does matter at your age, and to have that conversation with the urologist or your family care practitioner as to giving a referral to your urologist to discuss that PSA. But it's just part of your yearly screening that you should have, blood screening that you should have for other things that affect our lives, including high cholesterol levels, diabetes, etc.
Thank you.
Yeah,
Thank you.
I would just like to add too, hybrid visits are actually really becoming part of the norm now. So even if you do want to come in person, follow-ups can be a combination of video visits or even phone visits. And that's something a lot of people have apprehension about in terms of getting on the Zoom and being able to connect and do all of those things. And that's actually something we're really getting used to helping people through, and making sure that the whole experience is seamless.
Fantastic. And no matter what it is, they're going to make it work for you. And all of you people who are on here, you made it on this webinar. You can make it with a doctor too. You can be confident. Thank you so much for that. So I want to talk a little bit about the treatments for prostate cancer. Dr. Nanus, Dr. Nagar, what are those treatments? Are they all invasive? Are there clinical trials for cancer? Can you share with everyone?
So I guess I can start a little bit. That's a big question with a lot of answers, so I'll try and keep it very, simple. When a patient is diagnosed with prostate cancer, that's a big decision. What do I do? There's surgery, there's radiation, there's active surveillance, which means just, close observation and no invasive treatment. And it's sometimes difficult for patients to navigate that. What we have actually, I want to just throw this out there, both at all 3 of our hospitals, we have these multidisciplinary clinics. These are clinics generally for newly diagnosed patients that are trying to figure out what to do. And we set this up with an access nurse. The nurse helps you navigate through this, and you see a medical oncologist, a radiation oncologist, and a urologist who specializes in prostate cancer, typically all in one day. Sometimes it could be all in one video visit. And we help you understand your disease, help you reach what is the best treatment for you. And you can ask questions of the different disciplines. We talk about the side effects, what the different things entail and so forth. And patients are, really like that. They're very happy because they come out a lot more educated, and it's a group decision. And, we try, as Dr. Nagar said, and Dr. Graham, we individualize treatment. So there's not a one size fits all. Sometimes we'll say you have really bad prostate cancer. We really highly recommend you do this, but not uncommonly, there'll be a decision when we talk about it together with you and so forth. So, I mean, in general, when you're newly diagnosed, there's surgery, radiation, or observation. Today, there's also focal therapy. Men have a small amount of prostate cancer. Sometimes you can treat that small amount without taking out the whole prostate, but treating it with either microwaves or freezing. It's almost like analogous to a lumpectomy in a woman, where you don't take out the whole breast, just treat part of it. And that's a growing area that we're doing. And the advantage of focal therapy is typically less side effects. Obviously, there's the risk of impotence and incontinence or urine leakage that is paramount among many men. And we can address all these things. So, I mean, Dr. Nagar can talk about his technology that he uses for radiation, and Dr. Graham more about the actual surgical techniques. But, it's all state of the art, and most men have a very good outcome today.
Right. To sort of answer the clinical trials aspect, what we pride ourselves in at New York-Presbyterian and Weill Cornell Medicine is that we almost have clinical trials for every disease state in prostate cancer, because while, we are offering excellent care and technology, whether it's surgery, radiation, types of medicines that are available for patient, we know we need to improve upon that. So many patients that come to the door are eligible for various clinical trials, and we definitely encourage men to participate in these clinical trials, because it can help the future and help us learn and help them learn more about what's effective and what may be more effective. In terms of the technology we have, it's definitely state of the art in terms of trying to limit the side effects from treatment and maximizing the cure. Dr. Graham and I, both have our own individual methodology of treating. And at the end of the day, whether you choose one or the other, it's not generally about if one is better in terms of a cure, but it's the side effect profile that we look at. And that's where we're sort of chasing the localized disease setting. And then when you see Dr. Hakim and Dr. Nanus in the conversation, they would be more of where it's more locally advanced prostate cancer, potentially metastatic prostate cancer. And there's tremendous amount of clinical trials efforts going on in that realm at New York-Presbyterian, Weill Cornell, throughout all the boroughs. So, it's important for patients to understand clinical trials, understand how they can participate in clinical trials, because that's how we move the field forward. And all the advances that you're even hearing about on this webinar today is because of men that participated in clinical trials before, so we can provide higher levels of care to men afterwards.
I think, one thing I just want to echo what Dr. Nanus and Dr. Nagar said is, with regards to treatment, a lot of what ends up happening is an individual feels most comfortable discussing their treatment options with individuals that they meet in the community. Oh, I know that Joe Smith ended up with prostate cancer. Let me ask him. And then I think that that's really important for individuals to source information and to do their own research and to feel empowered. One of the things that Dr. Nagar and I always talk about is our goal is to empower a patient to feel comfortable making the decision with their treatment, how they want. Our goal is to give you the information to make that decision. And that starts first by gathering information and placing patients into different risk groups. There are certainly very low and low risk group prostate cancer, which has a certain recommended treatment algorithm where we actively surveil. We watch it very closely and we don't do anything invasive. And then as you move through intermediate and high risk prostate cancer, we introduce technologies like focal therapy, just treating the certain area with different energy sources, and then radiation and surgery. So what really this comes down to is making sure an individual isn't comparing apples to oranges. Their prostate cancer may be very different than an individual in the community, and that information that they're getting may not apply to them. So I think a lot of the treatment comes down to understanding where your risk falls, what your overall health is, and what you'll be successful with. Because we're talking about side effect profile here. We want to cure you, but an individual wants to minimize their side effect profile. So we want to make sure that you have the information you need in order to understand what may be best for your goals moving forward.
Fantastic. Thank you so much for that. Dr. Hakim, I would like to turn to you to talk about what distinguishes the New York Presbyterian prostate cancer program. You know, I'm hearing a lot of talk about, working together. But I know there's so many wonderful things about the program. Could you share some of that with us?
Yes, definitely. So one of the things that we have been talking about is how many people and how many specialties are involved with treating prostate cancer. And so what makes NYP really special is, as Dr. Nanus mentioned, we're not only in Manhattan, we're in Queens, and we're also in Brooklyn. And so that means being able to get high quality care close to your home. So for example, I work in Queens. If a patient lives in Queens and, they're seeing us at very close to their house, but, they want to go on a clinical trial that's perhaps open in the city, that is a very, easy way to get connected to that clinical trial, or sometimes we're able to open those kinds of trials in Queens as well. And, that's getting the same level of care across the entire institution. And then the other thing that's really, special about New York Presbyterian is that, we have not just talking about prostate cancer specialties, but also what are the other problems that you may, go through while getting your prostate cancer treatment. And we have, just in every single medical specialty, I'm talking, nephrology, cardiology, primary care, of course, palliative care, anything that you may need, we are able to get you into those clinics to see those other doctors as soon as possible.
Very helpful when you're dealing with a medical issue to know that you have a team behind you that can support you and be able to address all the different issues. And talking about that, what other medical issues do you face when you're treating a man with prostate cancer?
Yeah, so as we've been talking about the different treatments, a lot of our medications, for example, are well tolerated for prostate cancer. But again, with any intervention, including medications, there can be side effects. And of course, as a patient, it can be really hard to figure out how one treatment that you're getting, perhaps a pill or an injection, may affect a medical problem you may already have, or one that could possibly develop, such as common ones with prostate cancer might be, how can this affect your blood pressure? How, maybe your other organ systems, how closely do those need to be monitored? And then managing changes in your weight and your appetite, what are different changes in diet that may need to be considered? And that's a lot to process and think about while you're going through your treatment. And so again, just kind of harping on the fact that we're not having you go through this alone. And although as your oncologist, we're your primary, teammates, but we're not the only people on your team. And we'll make sure that we get the appropriate people on your team as well. And, kind of with that, it's not just about, of course, other medical specialties. It's about social workers. It's about, case managers. It's about making sure you get the medications you need approved and into your hands in a very timely fashion. And those are the things that we will do for all of our patients.
So it seems like it's about treating the whole patient, not
Exactly.
just prostate, but their whole experience throughout it. So
Elizabeth, can I just make two pitches just to follow up on that in terms of clinical research? So just as an example, in Brooklyn and in Queens, there's a clinical trial about men who are newly diagnosed and just getting educated before they see the doctor so they can ask the right questions. So these men who sign up for the study literally have a educator sit with them, help prepare them all the questions to ask when they see their doctors. It's been a very successful. We enrolled about 20 patients on that trial. I know Dr. Graham's involved with that. That's one example how the things we're talking about, we continue to evolve to try and make them better. We have another study which are opening for overweight men with prostate cancer on therapy, more advanced stage patients, but with a whole behavior modification and a whole food plant-based diet, where we enroll them on a special diet so they don't gain a lot of weight or they can lose weight, and change their metabolome to make it more anti-cancer instead of a pro-cancer environment in the body. So there's a lot of things we do. We talk about it, which we're all talking about, but behind the scenes, as Dr. Nagar said earlier, we do a lot of research to try and advance the field, which our patients participate in.
What about, I know something else that I know that you've talked about in the past about cancer boards, where the doctors get together. Can you share a little bit about that? Because I feel like that's such a unique, valuable.
Yeah, well, it goes back to what Dr. Hakim also said about how it's a group effort, or you said, Elizabeth, and we have, tumor boards that are held, which are very multidisciplinary, meaning that there's urologist, radiologist, pathologist, medical oncologist, radiation oncologist. It's the whole team. And the new patients that are seen are presented to the group. Each one's held approximately once a week. We have conversations, we talk about it. We're working together. Things get done more rapidly when Dr. Nagar and I present a case. I'll say, do you think this patient can get radiation to this area? And he'll say, yeah, I think so. And then literally when the conference is over, I'll call the patient, and next thing you know, the patient has an appointment with Dr. Nagar to facilitate the treatment. So it's really about getting input from all your colleagues about what's the best thing. And sometimes that's simple cases, sometimes it's very challenging, and it's good to get input from other experts in the field that'll help make sure our patients are getting the best possible care.
And to highlight and re-highlight what Dr. Nanus said there, it's not just who you're seeing on the screen right now. It's not just the treating physicians. It's the diagnostic physicians in the background that don't necessarily get the glory, that are a big input to this, because it's the pathologist, the radiologist that actually guide the treatment and help us make better decisions. So it's not just the patient, but all of their imaging and pathology that comes with it, that these decisions are made. And like Dr. Nanus mentioned, it's not nearly always a straight, clear decision. So we rely on our colleagues' expertise to do and recommend what's best for that patient, and then counsel the patient again as to the risk and benefits of undergoing XYZ in treatment.
It's always team. 2 heads are better than 1. But in this instance, it's 6, 8, 10 heads sitting around and discussing your case, your individual clinical scenario, having an active discussion in order to figure out, hey, where should we go from here? So whereas you may only see me and I'm the only talking head in the office, your case has been discussed with the panelists here today and several other individuals that play an important role, as Dr. Nagar said.
I mean, hearing about that always gives me goosebumps, because it just feels like you're really being taken care of. And, it also is a tremendous burden lifted off, knowing that you have some of the greatest minds in the world looking at your case specifically and being able to help. So thank you for sharing that with us. This has been so incredibly valuable. I want to get to some of the questions that our attendees have. So I know that the doctors have been answering them, but I want everyone to be able to benefit from it. So that's okay. I'm going to move on to some of these questions. James wanted to know, at what point should a doctor recommend a change from active surveillance to a more intense treatment?
I think that's a fantastic question. A lot of this, it's on a spectrum, and a lot of it's driven, again, to what we talked about before, where you are in your risk group. And when we talk about how you fall into that, there's so many factors. What was found on your biopsy, what your current PSA is, what your MRI may or may not have shown. So as you see yourself, we offer active surveillance at this point to individuals who have very low risk prostate cancer, low risk prostate cancer, and we have seen this evolve into individuals who have favorable intermediate risk prostate cancer. So a little bit more significant, but not a lot, and maybe not enough to push the needle into an area of treatment. And as it goes on, active surveillance, the operative word is active. We are actively watching some of those variables, your PSA, your biopsy, repeat biopsies as needed or every 3 years, something like that. We're looking for something to change that would push you out of your current risk group into a higher, maybe more volume, favorable intermediate, unfavorable intermediate, or God forbid, high risk prostate cancer. As you see yourself move into those other risk groups, you may find yourself being recommended to leave active surveillance. But that's what we do. It's just constantly recategorizing your risk group.
Thank you. Thank you for that. Matt had a question. First of all, he said, thank you for talking to us lay people with all this great information. He wanted to know, how often do prostatectomies lead to permanent ED and incontinence, and how long after surgery would someone know if ED and incontinence is permanent?
I think that is, I mean, that's it. That is what leads to today's discussion, because there's a lot of fear following, those two things. And that ends up leading to individuals not wanting to even start the process. As Dr. Nanus, when he was talking about fear earlier, you don't want to get to the end. So why even start at the beginning? The answer to that is to both. Okay. So again, we're talking about after your prostate is removed, an individual can leak urine. And then after your prostate is removed, you can have issues with erections. So first, let's go all the way back to what we talked about risk. If you fall into a risk group where you need surgery and you opt for surgery, just surgery isn't a one size fit all. I personally, we in my group here, we tailor the surgery based on your cancer. If your cancer is localized, if the MRI suggests it's within the prostate, it's on the lower end of the risk group, the nerves to your penis are up against the prostate. We try to peel those away and remove your prostate and tailor the area that can control continence postoperatively. So we have to tailor your surgery based on some of your risk factors. So how we approach your surgery is based on risk. So that's first and foremost. So when you're talking to individuals in the community, you have to understand comparative risk. How did Joe Smith, what was his risk group, and how was surgery approached for him as compared to me? But with regards to continence, individuals will leak urine after their prostate is removed, but we see that get better. We quote patients that 3 months after surgery, 70% of men are going to be dry. They're going to have one thin pad in their underwear and not leaking at all or very often at all. That continues to improve. At 6 months, over 90% of men are going to be, quote, dry, and that will continue to improve even up to 2 years after surgery. So that's the continence, the leakage of urine. With regards to your erectile function, listen, we have to be very honest with ourselves. The biggest determinant of your post-operative erectile function is an honest understanding of how good your erections are before surgery. They're not going to get better after surgery. There's nothing magic that happens in the operating room that's going to make your erection better. So if you have poor erections before surgery, it doesn't matter how much we tailor those nerves, your erections are not going to get better. Our goal is, if possible, to preserve as much erectile function postoperatively as we can. So we want to peel those nerves away and provide you the opportunity to see that erectile function recover in that 3, 6, up to 2 year time frame. However, one of my mentors used to always say, this is cancer. We go to the operating room to hit a home run, not to hit base hits. So when we go to the operating room, we want to remove all of your cancer. We don't want to leave any cancer behind. So the nerves, unfortunately, they're right next to the prostate. So sometimes we do have to sacrifice some of those nerves in order to get out all of the cancer. And that goes all the way back, individualizing your treatment, individualizing your surgery, and having an honest discussion about where you are today before surgery with your erections and what you can try to expect after surgery. But they will even themselves improve up to 2 years. If you have no erections, we still have medical opportunities, quality of life care here, where we can start to return them in some fashion. Medicines, oral injection, prosthetics, etc., if needed.
And let me just say, each of our institutions has urologists that aren't prostate surgeons, but that specialize in erectile dysfunction. So it's not that, the doctor's going to do surgery, say, oh, I'm sorry, it's nothing I can do. We have many people who will help you retain or regain your ability to get an erection through a variety of ways that Dr. Graham just mentioned. But you have to understand, we want to cure you of the cancer, but we recognize this is a problem for many men, and there are a lot that can be done. When I started in this world years ago, that was it. There was not a whole lot that can be done. Thank God with research, there's medications, injections, prostheses, a lot of things that can be done today to regain sexual function.
Thank you. Thank you for that. We have another question here, and I just want to come back to it because he was asked it earlier. Frank wanted to know, does blood in the semen have anything to do with prostate cancer?
So having what blood in the semen, also called hematospermia, does not indicate prostate cancer. It would be something very worthwhile having a discussion. It can be nothing, it can be something. So it should set off a discussion. And part of that discussion goes back into the screening, like we talked about before. And then it may involve, other types of urinary tests that can be in signs of infection, inflammation in the prostate. Does that inflammation or infection play a role in what your PSA value is? Certainly, as we've all said, elevated PSA values, higher than what would be, quote, normal, it can be elevated for reasons other than prostate cancer. And one of those can be infection. One of those can be inflammation, recent orgasm, ejaculation. So having blood in your semen should necessitate a discussion. It does not mean cancer, but it's definitely something worth looking into.
Great, thank you for that. Richard, want to know, is there a test that is alternative to the needle biopsy? For example, the blood test that measures the risk of cancer other than PSA. So is there something other than an alternative to a needle biopsy?
So a needle biopsy is the gold standard. We look at it under a microscope and we say yes, no, and then on that risk scale, where it falls. So the answer is there isn't necessarily an alternative, but it raises a really good fork in the road in that discussion. And what your meeting is when do you recommend a biopsy? When do you go to that? So even before that, there are other things that we can do. We realize that sometimes the recommendation of a biopsy is black and white. Your PSA, everything is normal, you don't need it. Your PSA is so high, your rectal exam is abnormal, your MRI is very concerning, we got to do a biopsy. But what about, and what you're asking is, I fall into the gray area. What else can I do? Well, certainly there's other urinary biomarkers or other blood test biomarkers that can help us understand where in that gray area you fall. Do you fall more towards the, maybe not having that bad prostate cancer, the clinically insignificant prostate cancer, or do these other biomarkers say that you have a higher risk of having clinically significant prostate cancer? And in that instance, we would probably favor proceeding towards a biopsy. But any replacement for a biopsy at this time, no, everything just helps us understand what direction we should go.
John, can you comment on the trial you're doing, looking at the different types of prostate biopsies?
So I think that's one of the things, thank you, Dr. Nanus, that we're really excited about. It just speaks to one of the advantages is our ability to exist at, the cutting edge of care. And first, it's just the diagnosis of prostate cancer. So a biopsy, we have at this point a couple different ways to offer you a biopsy of your prostate. We can offer a transrectal or a transperineal biopsy. These are just different types of biopsies, obtaining tissue from your prostate itself, but we're trying to minimize some of the risk and side effects and how the biopsy is done. So we're able to now offer a transperineal biopsy where, with some numbing medication and possible anesthesia to make you comfortable, the needle will track from the outside world through your skin and into the biopsy, as opposed to a traditional transrectal ultrasound where the needle will traverse from the outside world through the rectal wall where your poop is and into the prostate itself. There can be differences in infection. Our ability to offer a transperineal biopsy keeps your infection risk much lower, lowers your need for pre or peri-procedural antibiotics. So we're reducing a lot of what can be some of the side effects and bad outcomes, if you will, from your biopsy in order to maintain, a high quality of diagnosis and care. So we have that affordable and available to us, at all three of our campuses.
Thank you. And speaking, we have a question about, when you say our three campuses, how will Mark wants to know, will I get the same level of care in all of the NewYork-Presbyterian hospital locations? How is that continuum of care kept consistent across the different hospitals?
So I would say yes, definitely. You get the same level of care and you're in the same, institution, no matter which location you are going to. So again, with different modalities, different specialties and those tumor boards, those are not just specific to one site. For example, your case may be discussed with doctors in Queens, Brooklyn, and Manhattan. And so that level of communication means that you'll be able to get the same care, wherever you are. And if, for example, you need to go to another site to get the best care for you, we will be able to do that.
Fantastic. Thank you. Well, we could be asking you questions all afternoon, but I know that you have to get back to your patients. But I want to thank you all for joining us today. Dr. Nanus, Dr. Nagar, Dr. Graham, Dr. Hakim, thank you so very much. I want everyone to know I did put contact information in the chat. I'm going to put it there again right now so you can reach out to the doctors and make an appointment. You'll also get an email tomorrow with this information as well. This has been recorded and you will be able to have access to that recording. I'll send that out tomorrow as well. It'll also be available on the Schneps Media YouTube channel. Please feel free to take a look at it again and share it. We want to get this message out there because we want to make sure that everyone is getting screened and getting to their doctor and having these conversations so that they can be addressed. And I hope that you all learn much about the New-York-Presbyterian hospitals and the consistency of tremendous care. I see here these tremendous doctors, not only are they experts in their field, but so kind, and all of the New-York-Presbyterian doctors that I have met, I have felt the same. So, that means a lot as well. So thank you, doctors, for your time. I so appreciate it. Thank you to all of our attendees for joining us this afternoon. And I wish you all to stay safe, stay healthy, and we'll look forward to seeing you on a future webinar. Have a great day, everyone.
Thank you.
Thank you. Bye, everyone.
Thanks, everyone.